today. Today we are going to discuss about the importance of integrating occupational-based practice in OT services, in which the OTPPF is very important. Sorry, I have some ringing. Am I audible to everybody? Yeah, am I audible to everybody?
Yes, ma'am. Yes, ma'am.
Yeah, thank you. So, and following, we are going to see about a brief about the evidence-based practice in AS spectrum disorder. And then following, we'll have a small video assessments and discussions to improve your observation and structured and unstructured assessment process in free play environment. And finally, I could conclude sharing a case scenario in to make you aware about the documentation process. Before I begin, I would like to say, like, when I am working as a coordinator in scientific committee, like, we have been understood the need of shifting from the occupational model from the biomedical model. When I joined in Kuwait in PMR hospital, we had been mostly practicing a biomedical model. So here, if you see the current area where I'm working, in the period of that I joined, like, I had been seeing, like we didn't have environment or knowledge to integrate services for spectrum disorders. Like, so many referrals we received, but we as an occupational therapist was unable to provide the service for them. So it was really urging me and driving me to explore more about client to deliver the client service and the occupational therapy service. So in that aspects, like, a team of people we worked in Kuwait, that we work with the university. We have a Kuwait university, so they are PhD doctors and assistant professors. They are working in university, and we have a college of occupational therapy since 2005. So we formulated a team to update the recent evidence-based practice. So in such aspects, if we see a theory review, there was a great shift. We understood from 20th century, all the occupational therapists were been shifting their model of biomedical to the occupational based model, because we all know occupational based practice reflects the fundamental value of occupational therapies professions, because we use occupation as the media. The main goal is to provide the satisfactions. The client satisfaction is very important. Whatever it is, the final attainment is a satisfaction of the client, and then improvement in their performance skills in their context and the environment is very important. So it could be either from the individual, single individuals, or group, or the society. So and it has to happen in their own context and the environment. That is something very important. We know there are a lot of definitions for occupations. If you ask a laypersons, what is your occupations, they understood only the occupations is their job. For example, they say, I'm a technician, like, for example, for us, we'll say, like, occupation is an occupational therapist, but the real meaning of occupation is the activity that people engage in throughout their life. Each activities are considered to be an occupations in the occupational science perspectives. The occupations that they spend to fulfill their time in each moment by moment has been analyzed and assessed by the occupational therapist. So this is the core principle for the occupational therapy. The occupations really shapes the pattern of daily life. So it shapes the person's personality also, we can say. If I would like to share a few points for the best practice based on my experience. Like first, especially a pediatric occupational therapist, I believe the child guided and family centered are the main core aim of the therapist when you are practicing as a practitioner. The second thing is we should have a thorough knowledge about the typical and atypical development and all the aspects of the developmental skills, which could be physical, mental, social, etc., etc. And we should really understand the difference in application of servers in various contexts. Could be from home or could be from their environment, could be from the school, could be in the clinic, anything, anywhere. Okay. And then the next priority goes on generating the functional goal, because generating the functional goal really makes the persons more fulfill their personality, so we can begin with wherever they are. We will not just go on where we are, and probably we are studying a lot and knowing we have a lot of knowledge about the normal typical performance, where the client that will be sitting in front of you, maybe in a various low level or high level or moderate level. So if we go on their current level, it will really helpful for the occupational therapist to make their life satisfaction and to live a healthy, positive life. And also specifically for pediatrics, yani for all area exactly, but specifically for pediatrics, I experience family or caregiver should be placed as a central force, because when you see a fraction of life period, they are going to be with us. The child is going to be with us for a very, very tiny fraction of life period within us. But wherever with their family, with their real environment, they're going to spend majority of their time. So making the central force of family and their caregiver is very, very important. And not but the least, we should really honor and understand the cultural competence. Like as I was beginning to say, applying the spiritual, whatever it is. Spiritual is apart from religious, races, everything. So understanding and applying the knowledge of spirituality in your assessment process is a very important skill for each one of the occupational therapists. So all these goals up can be attained by applying our OT theories, OT assessments in clinical reasoning aspects. And you should create a hypothesis why such performance issues are existing, and then we will develop the interventions to improve the person's occupational performance. Yeah, because there are multiple activities the child can engage in. We have to understand and let the child, let the parents or the caregiver or the family to prioritize their concerns, and at the same times you have to understand why do the parents requires to fulfill their the child's occupational, wants, needs, and the expectations needs to be understood, and it has to be prioritized by using the various theory and assessment procedure. So if you put together everything, like we could understand all these are being like already have been formulated by our IOTA as a OT practitioner framework, like we call that as a OTPPF. So understanding about the OTPF is very important. I'm not going to spend much time on it, because as we all know, like we know what is like, this is like the ODPF, let us articulate the occupational therapy contributions to promote the health and participations of the people and the populations to engage in occupations in a very successful manner. If you talk about, like, we have four aspects. We have domains, process, approach, and the interventions. Like, if I want to talk about the domain, we all know the domains, like all the occupations are the outer core, the inner cores are the client factors. The outer cores are like we understand like where the child is there lagging, or what the family is lagging in which part of their occupations. What are their client factors, which is like impacting their occupation, which could be like value, beliefs, and spirituality, like and then client body functions and body structures will be assessed. And then if you go on to the focused analysis, we understand the performance pattern of the client. We understand the performance skills, like while establishing a specific activity or specific occupations. What are the strength and weakness of the client performance skills? And how about the context and environment? Could be a cultural, personal, physical, social, temporal, or virtual. So this is what has been represented over here. And yeah, in the pediatric surface, one of the most understanding is understanding the role of co-occupations, because co-occupations role, how we say a family is a core principle. Similarly, understanding the concept of co-occupations is something very important when we are dealing with the special needs, because the definition of occupational co-occupations says share and care part activities. The one currently we are doing is also considered to be a share and care, because what I gained through the experience, I'm sharing with you all, right? So this is something called share co-occupations, as simple if I wanted to understand. So majority and almost most of the activities are being established in terms of co-occupational aspects. Every, like if you take a family, like in a feeding sessions, if you take, mom will share, like she will be preparing a food and you will be helping mom to eat and say like give her a satisfactions. So it's a kind of start of analysis and understanding. So you should really understand what is co-occupations. Co-occupation is engagement of two people in the same occupations, more than two people or two people. Okay, so you can either share a physicality or emotionality or intentionality. So when we are applying our process of understanding the family, so we need to understand what is the role of a client and what is the role of the social members who's participating in the task. In which aspect they are taking a role? Is it like physicality aspects or emotionality aspects or intentionality aspects? Because this is the first step we do in the OT process. If you talk about the models and theory, there are a lot of models and theory. We really need to understand what is model and what is theory. Models are nothing but a specific methods or guidelines, and theories are the concepts or assumptions that can be extracted from the models. So the occupational model that we commonly, that I started integrating in a therapy is like PEO model, which I love to apply, because we could integrate a person, environment, and the occupations in it. And MOHO, which is the excellent model, OT models, which gives us more understanding about the necessity of intervening for the client. And theories are, yeah, I love sensory integrations because it gives you to understand the client personality. Yeah, if you understand the client personality, the sensory integration theory was really giving me a knowledge to develop a rapport with the child, with the family, create a good bonding, because you will be able to understand their processing abilities, so you will be able to honor them. Even like play theory, modal learning theory, neuromuscular theories, like lot of theories are available. In the OT process, if I wanted to talk about, yeah, OT processing begin with the collaborative between the practitioners and the client. In 3-panel dimensionals, occupational profile, like you create an occupational profile, you understand the client priority in terms of occupational performance barrier, and you'll start analyzing. So if you see, the first step of OT process is conducting an interview, interacting with the family members and the physicians. We get the referral from the physicians. So we really need to understand the reason for the referrals. Once we receive the referrals from the rehabilitation team members, like occupational therapy, really focus on understanding the functional difficulties of the family members and the client. So we really need to make the client understand what is the role of OT, how OTs can help. This is the first and foremost step. And then we will go on interviewing the parents about the sensory histories and occupational history, etc., etc. Our interview and the assessment process can begin with unstructured and structured observations. So in the evaluation process, step one is formulating an occupational profile. So here I have given certain examples. You can do an interview-based assessment. There are a lot of standardized assessments that are available. Like one is like COPM is a best one. I'll be like sharing knowledge of applications of COPMs and importance in my case scenario. Another is performance-based assessment. You can either directly observe from the client performance in their daily activities in the real life environment, or from the simulated environment. The assessments, like these are all some of I hope that you all aware, but here in our clinic we integrate these kind of standardized assessment during our interviewing process while formulating an occupational profile, because these are on an excellent tool which let us quickly connect, which is very less time consuming and fast decision making. So GMFMCS gives us an understanding about the current mobility pattern and stability pattern of the child, functional, not the quality of performance. So it makes us aware how far the child is able to physically access indoor and outdoor activities. And MACS, a manual ability classification systems, like which also makes us aware how the child uses their hands to integrate in performing the functional activities, like for example during eating, during writing, during establishing behaviors, and performing their play activities, leisure and play activities. So this really helps us a quick understanding about the child integrative process. And communications function classification system, it really makes us understand how is their child sender and receiver process in a familiar and unfamiliar persons and environment. So CFCS make us understand, connecting the client and the therapist, fast connections, and of course a developmental checklist. So these are all the tools that currently we are using to understand the activity and activity limitations of the client in a faster way. And unstructured observations are, we encourage free play. We understand transitions to and from the therapy space, how the child is like transferring or putting themselves in during the therapy clinic space. And also we request for the video from the parents and to observe the performance process of the child in the real life environment. What we look as an OT, we look for a sensory preference and needs. We look for the motor difficulties and compensations. We look for the behavioral organizations. We look for the play preference and the avoidance of the child. And we also understand functional limitations and strategies when we observe the video of the client. In addition to that, when I would like to talk about the sensory preferences, like we look for the vestibular functions because it connects the afferent receptors, because it is a two-way interactors. As we are OTs, we know the importance of assessing the vestibular functions. It could be either like vestibular functions connect us in three-dimensional way, motor way, sensory way, and mental abilities way. When you talk about the sensory way, it connects with like when you assess the vestibulospinal abilities, like you will be applying all the reflexes and its integrations, how the child smoothly connecting and making this environment successful integrations, because sympathetic and parasympathetic are the one, balance between the sympathetic and parasympathetic are the one which help the client to be successful in successfully using the environment in more meaningful manner. This is like foundations, like core, base core, we can say. As in also, while assessing the vestibulospinal functions, we understand the child motor abilities, how the child motor performance are, how are they doing a smooth coordinated, how are they using their body in more smooth and coordinated way, their extensor tone, their presence of postural stability, mobility, everything can be assessed. And another important factors are vestibulo-ocular, like how they are using the sensory informations, especially because sensory informations from the external resources, we use vision and the auditory, in which the vision plays a very important role. So vestibular ocular functions let us understand the child's processing ability. The another important thing is, we all know, like proprioceptive is the main modulator, right? So when you are assessing the proprioceptions, that you can able to assess and discriminate between, is it like a real muscle tone is affected, that means which is from the neuromuscular aspects, or is it from the muscle tone, not because of hypertonia from the central system, but because of poor feedback from the processing system. And we will understand the hypermobility of the child, joint mobilities, joint alignment, a lot of things, like a tendency to use the visual inputs. So all these are being assessed during when you are linked to the proprioceptive functions. So these are all the unstructured observations you can make. And the structured observations, clinical reasoning, if I go again, like when you are observing, you will be observing the reactions to the sensory input, because we have a certain set of cores to understand, policies, like points that you will understand. Okay, these set of points are belongs to the registrations. These set of points are related to the avoidance. So we started observing the child's registrations, avoidance, and modulations difficulties in a structured way, by implementing the sensory profile, by implementing the sensory processing measures, or by applying the SIPT, that we will be able to understand the child reactions to sensory input. And also we could understand that interactions with sensory experiences, how do they localize their visual perceptuals, visual motor skills, and how smoothly and coordinately and in a faster and quicker way they establish the interactions between the self and the environment, or within the self, will be like understand, and their arousal state. How is their state of arousals? Is it like an optimal band, or a low or high? Is that like low arousal is affecting their interactions within themselves and within the environment, or something else? Like we could able to differentiate that by applying the structured observation. And also again, so by applying all these, you can really understand the child limitations. Like here, I just wanted to know, like I hope these the Scheller's arm extension test, low RAM test, and finger nose test, these are all the some of the structure observation test, jumping jacks, postural measures during eye closed, standing with the uneven surfaces. These things are the structure observations which really helps, which like to formulate the clinical reasoning and a hypothesis for the therapist. When you say about the analysis is the second step of the OT process. Like when you are doing an analysis, first of all, we have to understand where we are focusing on, like what activities in the daily occupations that we are going to focus is very, very important. So after prioritizing that, like you either from the video or from the direct observations, so you will be understanding what performance skills or what body functions are, body factors are limiting the client to successfully participate in the daily life and in the activities in their daily life environments, in their own context and the environment. So when the therapist explore the child limitations, we should really zoom in. We should zoom in and make it in a very bigger picture, so that we can find a very refined clinical reasoning from that. We could say like there will be a small changes from the perspective of the occupations or the contacts or the environment or within the client factors, make a big changes in the alterations in the occupations. It really makes the occupations more successful. As we all know, every person is unique and different. Yeah. So yeah, so we'll identify and understand the participations and participations restrictions. So we will understand the current method or step sequences, how the child or the co-occupations is happening in their own real life environments, and their social relationship will be understand. And then we also understand the activity and activity limitations. We understand the contextual factors, which is like environment and personal factors. We observe the child behavioral response in their own environment and setups, in the aspects of physical, temporal, and facial dimension. So as I told you before, client factors are being like body functions and body structures are assessed through these three major functions: sensory functions, mental functions, and neuromuscular functions. And performance skills are being assessed by when the child is establishing the necessity skills. How is their motor skills? How is their social skill, interactive skills? How is their processing skills? So these are all some examples. Let us explore more about in the case scenario. Intervention process, the next step of OT is like, these are all the assessment and evaluations, clinical reasoning I shared with you all. From this, then the step 2 is intervention process. So you will formulate the hypothesis based on your clinical reasoning, the model you have chosen related to the performance limitations and strength and weakness. So that hypothesis helps us to formulate the intervention plan, intervention implementations, and interventional review. So in all these process, the documentations plays a very, very important role. There is a say, the people who write will be the most successful persons. So every time when you start writing, you apply a good ethical principle in it. Like only we just hear and do it. There are sometimes like we forget, we fail to notice in the time of interview. So always a continuous documentations. I always encourage my surrounding people that do our documentations. Documentations plays a very important role. Sometimes all the clinical reasoning that comes after you do everything, when you started writing in a sequential order, we as a therapist, we always look for the client as a therapist. We always say, no, they have difficulty to perform any occupations. If you wanted to be successful, you have to write and see like, oh, which step should I have to planning. This is called a planning. So planning is very, very important. So while you are planning your objectives, and you have to understand what am I going to look for it? Why am I going to give this? So by giving this, what am I going to get from? Where am I going to give this? For whom I'm going to involve the client, involve in the intervention process. Is it like family members? From the family members, who are all going to participate? So there are a lot of questions, a lot of W questions, a lot of H questions that you need to answer for within yourself. So clinical reasoning is nothing but your own reasoning, because in like clinical reasoning is a very, very critical word, I can say it, because it varies from each person two persons. Same persons, one therapist, like one practitioners do evaluations and understanding versus different therapists will always differ. But attainment, the final attainment is make the client successful. So you really have to understand, no matter what model, what frames that you use it, but final outcome should be focused on the functional focus. Yeah. While you are implementing the OT service, according to OTPPF, they have been categorized, and we also have to implement, like you can choose an occupations, activity, and preparatory methods, like what are all the methods that you use to prepare the child. Here where that we may use a kind of medical model here. Like for example, if you identify a child has a low arousal, so you provide an activity or methods to improve the state of our arousal state. Yeah, so that is called a preparatory method. So here we use preparatory methods and tasks. We use a lot of the frame of reference and theoretical techniques. Yeah, and then educations and training play a very, very vital role. Whatever you do for a client, get interacted with the parents and make the parents involved in throughout the OD process, because connecting the child with the family is the main important goal for the therapist, more than creating a bond between the therapist and the child. Of course, creating a bond between the client and the therapist is very important at the beginning phase to create a clinical reasoning of self for the therapist, not for anything else. So you will be as a model for the therapist, for the family members, and making the family as a therapist is a very important role for each one of the therapists. While implementing, you have to have continuously monitor the client response by documenting. There are various methods available in OT process. For example, you can use a SOAP notes, which is really, really helpful. We use a SOAP notes, subjective, objective, analysis, and then the plan. The SOAP notes really makes the therapist organize. Okay, am I going in a right way? Are the child is showing in real life environment? This information you get from the subjective feeling, and from the objects is what am I giving? What am I giving? How much durations I'm giving? What is my intensity of the therapy service? How often I'm going to see? When I am giving this, is it the child is responding for this type of interventions? All these will be written as a document in the O of objective under the SOAP notes. And in the third one of the A is you analysis what you are giving as an objective. Does it makes the difference in his real life environment? Will be like analysis between the subjective and the objective information that you have been gathered from the family members and within yourself. And then if you see a good progress, your plan can be continued. If you are seeing very slow or late, or if you feel the reason, you find a reasoning, probably in most of the circumstance, like a therapist notices a big changes in the child attitude and interactions and the skills within the therapy clinic, but in the home that you might not be able to find a time. I mean, they might not integrate it properly. When you understand, you will know how to facilitate that. That is also very, very important. Continuously monitoring the child progress in the real life environment is very, very, very important role for the therapist. And finally, you modify or review the goals as per the need of the client and the client family. So targeting outcome, the third phase is the targeting outcome. So you will see where the outcomes are happening, and you will adjust your goals and interventions accordingly. So this is what we have discussed right now. These are like how to frame a clinical reasoning. So far, what I have been taught, discussed with you was the thing, like the clinical reasoning, which gives you like what model you're going to take, which populations you're going to apply it, which ICF level that you are addressing for, which setting that you're going to look forward for. What are the science behind that model, theory, and treatment approach? What is the evidence? Evidence-based practice is very, very important. Still, there is a myth between the evidence-based practice, but evidence-based practice give us a confirmation, especially for the beginners. Evidence-based practice improves the way of exploring and applying the models and theory in creative manner. Model or imitation is something it will not just zoom in like that, right? Like we need imitations and model for the beginning. Once you begin, then you can then you can apply your own creative thoughts, right? So that is the specialty. Specialty of each OT is a creative thinker, right? So you apply in a multidimensional, one aspects you apply in a multidimensional. So here is the model, like I have been given over here for your clinical reasoning, all these. Like if you ask about the sensory integrations, just an example, what science that supports underlying assumptions? Yeah, neuroscience, occupational science, and therapy are being like underlying on the sensory integrations theory. And what disciplines can use? OT, PTs, even speech, they started using it. And the goal of intervention is sensory processing, creating an adaptive response in three-dimensional aspects or in a multiple dimensional aspects. I can say motor, arousal, attention, purposeful interactions, motor planning, social communications, etc., etc. And if you talk about the intensity, frequency, and length of durations, we have to understand how often I'm going to give, how much I'm going to give, how much length I'm going to give it. So if you are working in an organization, what is the organization's policy? What is the policy of the theory itself? Because a lot of evidence says the intensive SI for continuous 6 months will make a changes in their developmental process. But if our goal is not making a change in a complete typical performance in their life, but more than that, a satisfactions and creating a changes in the current occupational performance. So you have when you are selecting the precise occupational performance and participation difficulties, you will be able to hypothesis and judge how long you want, how often you're going to do, what are all the methods that you're going to do. So all these clinical reasoning you will extract from this point of references and ICF level. Yeah, so international classifications functioning was like saying, I hope you all know about the ICF. Like participation is the main outcome according to ICF. So for the participations, which body functions and impairments and activity or participation is limited will be understood by using the sensory integration model and frames. And you will understand the context and the settings. Where are you going to make a changes? Is it in the clinic or at the home, or what is there? Like intrinsic motivation is very important. So you make a change within the child inside, okay? A personal causations. If you talk about the MOHO, it's called a personal causations. You make alterations in their child internal motivations and drive, okay? So yeah, so this is about introductions about the OT. I know I had seen a lot of beginner OTs are here. So I hope these clinical reasoning are going to improve your process of thinking. If I talk about the spectrum disorder, I don't want to much spend over here, but even it is like today is an awareness day for a spectrum. Spectrum is a combination of restrictive and repetitive behavior. I really want to say, like, they have deficit in occupations, communications and social skills, interactive process. On my experience, if I wanted to say, every one of us have a spectrum behavior. If I want to just see a behavior, honestly, every one of them, of us, not them, every one of us are having a spectrum behavior. I just want to take as a behavior. There are a lot of repetitive and restrictive behavior. Like we'll say, I only like this, I only like to do this, I would like to do in this way only, I only eat, I have my own habit, I have my own rituals, I have my own. So whenever we say I have my own limitations, if you are limiting yourself, that is called spectrum behavior. Yeah. So spectrum is not what to say, stigma. It is ruining over every human being. Like if we wanted to break and come across, we have to understand, why am I doing? In any circumstance, I will prepare myself to adapt, flexible, and get into it and make success. I prepare myself to tolerate, sacrifice, and adjust in my demand, either within myself or within the environment, right? So this is something generally, like this is what I understood by the spiritual principles. Yeah. So the same thing was being proved in the neuroscience also. A stress factor is the major reason for the spectrum disorder, meaning they fail to create a balance between the sympathetic and the parasympathetic activities. So whenever there is a poor balance between the sympathetic and parasympathetic, your body, your mind, and a complete human personality behavior will be having an alterations. So understand the neuroscience, current existing neuroscience says there is a big difference. Imagine we are in a COVID situations, like people in stress, they, without knowing a stress, they mentally feel that all the negative feelings are considered to be the stress, right? When you have positive, because if you prepare yourself to live and face the situations, your system, that your sympathetic and parasympathetic systems are working in a balanced way. If your sympathetic and parasympathetic systems are not working in a balanced way, either mentally, which is a thinking capacity, the thought processing will not work. You will have a great block in your thought processing. Similarly, if there is a great the block in your thought processing, you will have difficulty with your physical factors and etc., emotional factors, blah, 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 everything, all dimensions will be like collapsed. So this is something like a core, like we understood. We have to really, so it creates the inefficiency to face the challenges, okay? The really strength and weakness of ASD, according to, spectrum disorder, according to evidences are, there are evidences, they are very good in visual spatial perceptions. This is their greatest strength. Like this was being proved in multiple studies. The weaknesses are, they have difficulty to process the afferent informations. Yani, whatever they have it within themselves, they will establish and execute in their a certain pattern. They fails to apply that in the variety of pattern, and that their pattern precisions and personality, like performance, will be altered from the normal expectations. When we talk about the expectations, every individuals differ from their expectations, right? Like for example, I expect my child to be a doctor. Commonly, let's talk about, okay? Another parent may expect, I expect my son to be a player, for example. So being a player or being a doctor, being an engineer is the expectation of the parents, not from the child. The real integration is understanding, creating a smooth interactions between the child and the parents in professional selection. Is each other, what do you like? Okay, this, okay. So being flexible, this is what is like you have to process this informations in the thought. So while for process the informations in that thought, your environmental stimuluses needs to be combined and cope up with that. The coping skill is very important. If we are rigid, then we fail to flexible in the situations, and that cause a lot of stress in both parties, right? So similarly, what is happening for the spectrum a child is they fails to process the informations in the afferent fibers, because as I was discussing before, the vestibular creates a lot of, when you understand the link, the behavior with the vestibular, somatosensory and proprioceptive, this gives you a complete understanding about the child. So this is how we understand. So it is not only for the mode of performance, even the way they interact the body within the context of the environment makes the person balance not only from the sorry for the interruptions, not only from the physical aspects, also from the mental aspects. Yeah, so the child will, because of that, they have a clumsiness in the mode of performance as well. These are all some evidences. Again, they talk about the hyporeactivity is the major features of spectrum disorder. They don't know, unawareness in our aspects, OT prospects. If you wanted to say a poor ideation, they have poor conceptualizations of ideas. They don't know how to use the objects, tools, even their own body, they don't know how to use it. So this is the great limitations for the spectrum disorders. For example, if you don't have an experience, but suddenly imagine that you are in a path where there is like only one slides are there to cross a river. You have never have an experience to cross, like walked in a beam or something, where you only have a beam to connect between the rivers. You need to cross it. If you don't have an experience, or if you don't see like how to use your body, your internal body is not alerting or giving you the to take the challenge to cross the bridge, then this is a stress factors for you, right? So similarly, if your body creates internal feedback, come on, let's take a challenge, then walk across. Okay, I have to narrow my feet. So your body have to get the internal feedback. So internal feedback is a very important for motor planning the task. Yeah. Sensory features. There are strong evidence that lack of response to name, and poor visual attention, and excessive mouthing, and poor social touch awareness, all are very evidential due to the problems with sensory processing. There are a lot of evidence says like the child with the spectrum has modulation disorders, and they fails to modulate the environmental stimulus within the body and with the environment. So in SIPT test, sensory integration and praxis test, Smith and Raleigh in 2015, she has been like included imitation praxis, somatosensory perceptions, the vestibular bilateral function, sensory reactivity are the greatest weakness for the spectrum, and strength is their visual perceptions and constructional abilities. Yeah. So commonly, these are all the assessment and the intervention techniques we were being like applying worldwide, in which the OTs are more focusing on applying the ASI principle because the spectrum disorder is considered to be a sensory processing disorder, one of the sensory processing disorder. Other techniques are behavioral approach was really helpful. A lot of evidence says DIR flow time, social skill training such as parental educations. These are all the approaches that we are using for spectrums. Child-focused interventions, environmental supports and adaptations, and caregiver and focused approaches. Yeah, coaching really helps a lot. Parent and teacher mediation of activities are very, very important. Yeah. And during the assessment process of the spectrum disorders, building a skill, understanding the play, like being an OT, that we use a play as a media to understand the child in a multidimensional aspects, because multiple intervention strategies are being like emerged by play theory. And then like especially child with spectrum, they have their own stereotypical features. They have lack of symbolic play. They doesn't know how to use the tools and objects. Because of that, they don't know. Because of that, they have poor flexibility. So it is a very, very important responsibility for every one of us to guide and make them understand in the simplest way, so that we create a successful situations in their life, right? Yeah, so through play we understand, like we can build up all these skills, sensory skills, and then like behavioral skills can be like improved by letting them involve in play activities. If I want to talk about the ASI, I can talk about a day, but by considering the time, yani, like I would like to really love to share the art of therapy, because like SI requires a conscious effort for the therapist. Each and everything you have to listen, observe, and communicate. Communication is not a big barrier. We always limit ourselves. Communications means only through articulations, but silent is the best method of communications. If you start exploring the importance of silence in communications, if therapists are in a state of calm and observe, not interrupting, not talking, a lot of learning can occur, because we don't know what is happening for the child when you are implementing. If you are silent, don't provoke, just observe their free play where the child is be with you, and just be a facilitator. Whatever you have, it differ from each person to persons. Just stay calm, and if you wanted to make a successful, just create and try. Probably a lot of trial and error is necessary for the therapist to know. No one will know as soon as a child comes in, yeah, this is a problem. The more trial and errors you attempt, then you can make a hypothesis. Okay, this is what the child requires it. Yeah. So this is the importance. This is the art of therapy. Therapist will have packet full of activities, like whenever the child need, you will take and give. That is the reinforcement. Yeah. So we use play as a media. Like another science behind us, this type of approaches establish a good rapport for the client and the therapist, client and the environment, client and the family, etc., etc., because it taps the inner drive of the client. If you create a successfulness for the child, that's the child will connect easily with you. Okay, what all we needed, we have to need a patience. When you are in a calm state, you are able to guide the others, right? If you are having a multiple things in your brain, you cannot so this is very, very important. Your conscious effort, I mean therapist conscious effort is very, very important, and all these have to create a safest environment. You have to plan and facilitate the goals. You have to create a lot of freedom, create a balance and the freedom within the structure. And you have to decide like what type of therapy that you like type of service that the child requires, techniques that child requires will be concluded at the end. Okay, these are all some evidences to improve the participations and behavior. Social skills training, yeah, it's a strong evidence. Okay, because the social skill training are being intervened by involving the family and the society. Yeah. So behavioral strategy, which also has a strong evidence-based support. These are all the systematic review support, my dears. I hope you all know what systematic review is. It is type 1 evidence, okay? Strong support to use a behavioral strategy within their context, not everywhere. So within their context, OT will understand, like within the context, that is a big difference between the real behavioral therapist and the OTs, because the difference between, like on my explorations and understanding, I make a difference between the application of behavioral techniques between the behavioral therapist and OTR. Behavioral therapist can take all behaviors. Yani, for OTs, we take the necessity of contextual behaviors within their environment. So that precise applications was helping the client to be successful in the current level. Okay, so everything should begin from the current level, not from expectations of everyone's, right? use of technology. Yeah, so even though we say technology is creating a lot of restrictions, but evidences says like mobile, tablet, because their skills are visual perceptual skills, visual spatial skills are very good, so they can interact with the technology best than the real environments. Yeah, interventions to support ADL and IADLs, moderate evidence only available. I hope together we are create a strong evidence, because we should be proud to say we are occupational therapists making a changes in the occupational aspects of the every individual. So still, even though the evidence are variable evidence, but still requires more, we all together work on it and create a lot of strong evidence, find a lot of approaches. So I wish you all the best for being a good researchers. So I bless you for all the research minders. Yeah, so the evidence of like currently if we say co-op creates a lot of evidences for occupational based model, and OTSI, intensive OTSI, was really also creating this. Not but the least, yoga and exercise make a great changes. If you see from the current situations, every one of us are running behind the yoga, exercise, physical activities in everywhere. But for the clients, yeah, there is a great evidence. The yoga, exercise, and group physical activities in their it helps us to improve their classroom performance, behavior, and the social readiness. Yeah. Okay, the family center practice is very, very, very important. So like I'm not going to talk about more. I talk a lot because one thing that you have to keep in mind is the child is only going to stay with us for a fraction of their life, very, very minute fraction of their life. A family and the society is the main focus. They are the central core. Family is the central core, creating a bridge between client and the society, client and the natural environment. So educating them, highlighting the awareness, preparing them to make the child success in their real life environment is an important role in family centered practice. Yeah, so but generally, like OT uses the data driven decision making process. We identify the challenges, we describe the current level, we identify the factors affecting the participations, we conduct assessment and identify the strengths and barriers, we generate a hypothesis, we design and choose intervention approach, we identify the outcomes, conduct and display the analysis data, and monitor the process. All should happen in a very structured documentations manner. Yeah. So this is what I would like to discuss about theory. So I was just refreshing the theory and model. So here, yeah, we run through the slides of documentations one. So this is the client of 6 years, 7 months old. I hope I have 10 more minutes. Yeah. So this child was, this is the way we document here. I'm not going to read all these. This child was being like from the beginning of the year life, he was being taking physiotherapy because of his low muscle tone and developmental delay. But this was the first time when he was only 6 years and 7 months, he attended the first OT sessions, and it was evident the indoor and outdoor mobility was adequate. But he has a history of, meaning he was using the walking, but he has a frequent fall. He can able to climb up and stairs with the support. He's easily fatigued and tired. For short distance, he will be very tired. So he was using a kind of wheelchair for the outdoor mobility also. For long distance, his manipulation skills was very poor. He is unable to establish his self-care and the writing tools, so which affects the quality of performance and quality of the family. The communications was inconsistent with and unfamiliar, where the familiar partners were understood. So profile, like, yeah, I told you, GMFM level, if you see these levels, yeah, levels are these. And occupational difficulties, quite a level good, levels are good. So we had a hope, yeah, we can able to educate and train the child in establishing independency. So occupational difficulty complaints of poor feeding establishment, poor dressing, toileting, play, school, and stair climbing. And his routine evaluations reveals he requires a lot of physical and verbal supports and guidance to establish the self-care and the school task. During lunchtime, he does not complete his meal, and he is unaware, like in the feeding itself, because mom prioritization, COPM prioritization was like feeding. So like she was been complaining about the feeding. He doesn't know how to open the sandwich, juice bottle. He requires a complete physical support. He doesn't know how to insert the straw. During dressing, he requires a maximum support to button and unbutton. For all the groomings, the child is completely dependent, and a habit was a shy and very passive child, and play also always alone, does not play with others or siblings, peers at schools, no friends, hesitate to interact with her peer, more than school and the school and then the house, social environment. Habit of excessive spillage and destructive behavior during feeding, slow writing behavior, no rituals except playing alone, roles, daughter, sister, and student. Personal concern, values, and interest. Our parents would like to improve the child performance of self-care, especially during feeding. As she was worried, like she was telling that her belief that poor during feeding during the school was like her affects her quality of she's afraid that the school performance will go low. And on observations, her postures was like poor. This is like sequencing steps of step sequences and the task of feeding. Mom prepares the food. Child is being seated in the regularly in the chair where her feet is not supported. Table is at her shoulder level. She holds a spoon in an awkward pattern. Independently scoop 3/4 spoonful of food. These fine informations are very important when you are reviewing the performance task. Take it to the mouth, spills food excessively, makes the place very messy. Multiple time drops the spoon down on the floor. Always mom needs to pick up and hand over the spoons every time. Every 2 to 3 spoonful, she looks around and watches others. Only after mom continues her, mom has to continuously give her the instructions. She takes more than 45 minutes to 1 hour to complete the half plate full of meal, and most of the time she has an incomplete completion of food. She requires total mom supports to open the bottle while drinking the water. She requires total support to insert the straw in the juice packet. She holds the juice packet very inappropriately, shows she has a lot of excessive spilling. Requires total assistance to peel off the fruit skin, especially banana. She was like very fond of banana. She is like she requires the total assistance to unwrap the sandwich cover. And the tools, supplies, equipments, and social demands are these. She uses the medium-sized plate and plastic spoon, and supplies are rice, curry, etc. And equipments are table and chair, and social partners are mom. Mom is she was giving a more physicality and intentionality support to make a complete and with more organized way. The special tests we performed are we integrated sensory profile. We provided unstructured observations for the reactions for sensory stimulus during free play, touch localizations, finger isolations, finger nose test, catch and throw the ball. Therapy ball test for writing equilibrium and productive responses test, balance test, static and dynamic standing on uneven surfaces, dexterity board test. So these are all the special tests we have been integrated. And the client factors analysis reveals for the task, she exhibited decreased tactile awareness and discriminations was evidential when we were doing the finger localization test. She also exhibits poor vestibular processing, that her posture mechanism is poor. She's clumsy, disorganized, fails to adjust her body during the static and dynamic movement. Decreased visual processing, she's easily distracted. She's very slow and delayed response for auditory. Every time multiple requirements, multiple commands is required. And motor functions are, she exhibits inadequate muscle functions. Not exactly from the neuromuscular aspect, but from the processing aspect. Poor proprioceptive mechanism. Afferent fibers are not working adequately. So this is how you generate a clinical reasoning, generate weakness, especially decreased extensor mechanism, which was evidential, like extensor tone. The extensors are more related to vestibular and flexors are more related to the tactile, for your kind information. So she also exhibits inadequate movement functions. She had very delayed writing and equilibrium response. She was like not adjusting her body when they were been using her in a therapy ball was very evident. She had a poor score in standing balance, fails to stay still while visually occluded the visions. She has fails to stay still on the mattress. She had poor body on body response, which is internal feedback was low. Poor eye hand coordinations was very, very evident. Decreased fine motor coordination also was evident in the dexterity test and pegboard test. She exhibits adequate muscular abilities to reach. Yeah, this is what I said. Like she has an adequate, but she has inefficiency. Yeah, able to reach, grasp, and release, but she has inefficient way of manipulating and adjusting the tools and objects within her hands. So basically, we conclude she has a poor feedback responses in motor aspects, even though she has a good motor skills. Yeah. So her mental functions are very inconsistent and inefficient. She had delayed and low arousal states. Her attention and her orientation response to the external and internal stimulus are very inefficient and inconsistent. She exhibits decreased tactile perceptions and discriminations, which was the core factors for poor internal feedback. And her internal, her attention, visual attention was like low. She easily loses her attentions, and sustained attention was poor. Poor motor planning and sequencing. She fails to generate a force appropriately. If you see the environment and context, physical environment in the feeding process, it was inappropriate table and chair. It was a distracted environment because she was sitting with the family and eating. She was looking at each family members, and she has the ritual of looking at the TV or the monitors while doing eating. So which was like she has a lot of visual distractors, like which was being mentioned in the visual. And temporal was she was taking too long time to complete the meal. Social support was, either the child or the family doesn't have the knowledge about how to facilitate, and they have been giving a lot of physicality and intentionality support. They don't know how to, divan the support and how to facilitate the child independency. And personal factors are poor sensory processing ability was very evidential, and her state of arousals and attention was low. Not inconsistent, it's inefficient cognitive skills. She has cognitive skills, but she doesn't know how to effectively use it. Okay, so this is about the performance skills, motor skills, like while establishing the feeding task, especially the meal time, the child often slunges, fails to maintain an attentive position, leans and supports her hands on the table always. She was like lying down while eating. She exhibits immature and inconsistent pattern of grasp to hold and uses supplies, poor coordinations, excessive spillages, often drops utensils. If I talk about the processing skills, shows decreased and inconsistent awareness. She doesn't have an awareness, knowledge, attention to actively participate during feeding process. She had what conceptualization of idea and lack of knowledge about the use of supplies and utensils. Like she is unable to open the feeding the water bottle. She's dependent. She's unable to put the straw. So a lot of supplies and utensils she doesn't know. Even though she has the adequate motor skills, So poor planning of motor actions, fails to consciously continue and complete the feeding process. So her conscious efforts are very low, often drops spoons, which is also evident for the consciousness. She's not consciously doing, she's just making it like that. She doesn't have a drive to complete it because she's like, her attention was everywhere, and she doesn't have the motivations to be as successful. She doesn't even aware that this is my role. That opportunity was less. Like she takes too long to complete the meals. Okay, interaction wise, the child is very passive, slow interactive responses, inconsistent and fails. At times she can, but she requires a continuous intentional supports, fails to take turn. requires mom's complete interactions and to complete and successfully complete. If mom was taking away or something, she's emotionally upset and instability. Yeah, so this is the functional statement format. If you see here, child fails to maintain upright attentive postures, uses physical environmental support to stabilize upper body function, upper body while seated in a dining table due to, so we refine the clinical reasoning, yeah. So we select specific activity limitations and the factors influencing. So this has been like therapists have identified hypothesis. This is the hypothesis of performance limitations, yeah. This is due to inadequate somatosensory feedback, vestibular dysfunctions, and visual attention. So if these are being given, her posture can be like internal feedback can be developed. This was the hypothesis. And the second problem list was requires mom and caregiver maximum more than 80% of physicality and intentionality support to continue and complete the feeding task due to poor processing. She is easily distracted. She has poor internal motivation, inconsistent state of arousal, sustained attention, poor ideations, and sequential process. Incomplete completions and take too long time to complete the meal due to lack of intrinsic motivations, low arousals, in addition to poor environment and contextual support. So for the second problems, I can even add a social limitation, social context limitations. Mom doesn't know how to promote also, okay? And the fourth problem statements are exhibits inefficient feeding utensils, usage of feeding utensils and supplies, requires 100% supports, such as opening water bottle, peel off banana to insert straw to juice bottle, due to decreased tact proper discriminations, like finger isolations are not adequate, she didn't develop it, poor feedback mechanism, inefficient fine motor manipulations and motor planning. So for this, if I wanted to make a long-term goal, you can use, like here we are using either A, B, C, D, E method or a cost format. So here is like, you can check later on. I can share you the PowerPoint of the case scenario. The child will be able to maintain appropriate attentive postures and be able to complete his half-plateful meal within 30 to 40 minutes with minimal 25% physical and verbal support in 2 days per week within 12 OT session. The next goal, long-term goal, is a child will be able to open his sandwich with only minimal 25% verbal cues without physical support in 2 days per week within 12 OT session. The client will be able to efficiently use feeding utensils or supplies, such as able to open water bottle, able to peel off banana, able to insert straw, with minimal tactile cues in 2 days per week within 12 session. The short-term goals for all these are to provide the family education was a main short-term goal about the child's sensory processing strength and weakness, and teach sensory diet and strategies to integrate at home to facilitate feeding participations, as well as to engage a child in purposeful play activities during family leisure time, to recommend appropriate size and table, to change the context and the environment, to provide tactile and texture-based activities to improve the tactile and proprioceptive skills over his hands and increase the efficiency of fine motor skills, so that we can able to develop the child ability to use the utensils. And by the SI point of view, as a preparatory methods to provide the tonic and phasic. I don't know, are you all aware about the tonic and phasic? This is the high clinical reasoning of when you know the ASI principles. Tonic is something like sustained one. Phasic is a quick one. If you give the tonic, the linear inputs are called the tonic input. Linear and horizontal input using a bungee. It creates the postural tone, and arousal, sustained attention can be developed by tonic. And phasic are quick movement, quick inputs, where it increases the short attention span and the short quick arousal state, yeah, but it will be like lost within few minutes, but tonic will be for longer minute, yeah. So tonic and phasic vestibular input to improve his state of arousals, attentions, also to build up the postural tone to facilitate the attentive postures during feeding, encourage obstacle activities to improve his ideations and motor planning and somatosensory feedback, so that she herself to find a way to take a spoon if it drops, and or she will act as a more conscious effort, yeah. So provide graded and guided activities in rehearsals, practice and sequential tasks from simple to complex to improve her play behavior and the performance. Activity time scheduling for habit training, teach hands-on hands techniques. Yeah, so we are reached now the target outcome. We use two target outcome. One is the GAS, goal attainment scale. Another is the target outcome of COPM, which is very evidential. This is why I say documentation is very important. Creating the satisfactions to the family is very important. So like, I don't know you are aware about it. The -2 is very, very, like, the 0 is the expected outcome. The -1 is a minimal outcome, then the expected. -2 is the very minimal, then the expected. +1 is above, much more than the expected, more than the expected outcome. +2 is the much more than the expected outcome. So if you see, the variables we used are the percentage of usage of completing the feeding process by 60%, 40%, 25% requires assistance, whereas here 60% in -2, 40% in -1, and 25%. But we alter much is, these are all 1 day, 2 day, 2 day, but here all day, 4 days, 25%, but all days, all 4 days. Whereas in the much more than are all the days that the child will be like taking a very minimal support, physical support and intentional support to complete the task. So this is how, because by considering the time, I'm not discussing everything. Maybe I can share, if you want, you can use it. I will share with Mr. Rakram. And the COPM, if you say, it's very, very evidential. So if you see, these are all the 5 factors we have been identified, me and the parents, and the importance of activity. If you reveal, I don't know whether you have been aware about the COPM. To teach the COPM, you need to have a separate lecture time, but I'm just showing the differences. This is the date, like if you see 5/5/2020, this is like re-evaluations, second performance and satisfactions 11/6. So basically performance and satisfactions are being evaluated by COPM. This was being filled up by the co-occupant, because co-occupant is the mother is the main caregiver. So initially the performance was like using a spoon during meal time was 3, which is like a rating scale. 3 is a low performance, and at the end mom was saying 7 is a performance. So like that in each and everything, if you see at the end, if you have these two are the pre and these two are the post, if there is a difference of 2 points, that itself, the statistical evidence says it's a very high. If you wanted to do a case study, this is a very high evidence. Yeah. So initially, by calculating the sum of satisfactions and performance by problem skills, it was 1.6 performance, and satisfaction was 5. And at the end of the sessions, it was like same person we have to integrate. So 6.2, from 1.6 to 6.2, the performance level, and the satisfaction of from 5 to 7.2. So it's about like, it's a matter of huge difference, marked difference, which was really understanding the application of OT and the techniques and interventions was very successful for this child. Plan was like occupational improvement and participations. Approaches are, these are all the approaches. We have been used some of the task of tonic phasic movements. These are all the texture-based activities. These are all the preparatory tasks that we had been introduced. Yoga and finger twisters. Yeah, this is a great activity. Push down jazz, tug of war, group activities. Yeah. So this is the home program, time scheduling, creating bonding between the child in the flow time manner. The task simplifications, and then home programs to strengthen. Yeah. Yeah, so I'm done. So I'm sorry, I think I took a longer time.